In my ear. I have a very bad habit of talking fast. If I'm talking too fast, just say slow down. Okay? Very good. All right. Very good. And also, just a couple of comments to the previous questions a second ago. Am I hooked up here? Let's see. Let me check. Yeah, okay. Let me just... Oh, that should do it. Let's sit down.
Don't worry.
There we go. Let's make sure the screen is up. Okay. Okay. Anyway, a couple of comments to the questions a second ago. The concern was about selective reduction and the risk of coagulopathy in mother. This has nothing to do with my present talk. Selective reduction, where terminations are done prior to 24 weeks, there is not a documented case of DIC in the mother. There are documentations of laboratory changes, okay, but you don't, as Edward said a second ago, you don't need to follow coagulation patterns in those women at all. When you get into late terminations, 29 weeks and beyond, that's an issue, all right? So just as a point in that regard, we do not follow them. We have had situations where clinicians have done this testing inadvertently, found fibrinogens that went low, and started chasing a laboratory test without following a patient clinically. So you will get a shift in your coagulation pattern, but unless the patient is clinically symptomatic, you don't need to fool with it. Okay, so that's just a comment on that. Now, there are also a couple of questions or statements about selective termination and issues along that line. That is actually my second talk, so I'll be addressing some of that. But the one question that was brought up by Dr. Grotakos in the context of the family unit, the incidence of divorce in women who address these issues with regard to selective termination is at least 50% in most studies. It's a very, very difficult situation, and we found that a critical component to the process of counseling here is psychologists. Having a psychologist participate on the front end to work on the family unit is critical when you're dealing with fetal malformations, okay, to hold that unit together. And quite often, like in many situations, the husband walks. He can't deal with this. The mother's having a very difficult situation. So it's critical to get counseling in very early in these cases. Enough of that. We'll come back to it in the next talk. Yes, where we are in the U.S. right now, since I started my program a long, long time ago, we've seen an astronomical increase in the incidence of twinning. But the relationship between monozygotic and dizygotic twinning really hasn't changed. It's still a 3-to-1 relationship. So that when we look at things in the U.S. right now, aside from what our reproductive endocrinologists are doing, which is causing a 10-fold increase in monocorianicity, the incidence of monocorianicity remains the same, about 1 in 300 pregnancies. But when you add in the incidence of what the reproductive endocrinologists are doing, we're seeing a big bump. So in the U.S. this year, we're going to see something like 24,000 cases, okay, of monocorionic twinning. Right? Overall, roughly 1 in 170 pregnancies will be at risk. Now, considering that 30% of those are going to have a problem, this is a huge risk population. Now, some of the things that I'm going to be talking about this morning, twin-twin transfusion, this talk, I'll be addressing TRAP, or twin reverse arterial perfusion, and discordant malformations later. Dr. Grotakos, I think, is going to be talking about growth discordancy. I'm not going to address monoamnionicity during these presentations. There's not enough time. Now, some of the interventions we'll be talking about, amnio reduction, septostomy, laser, bipolar, and RFA. This was addressed in the first talk, but just to reiterate, this is a quote that some of you may have heard before, but it is truly the truth. There is no diagnosis of twins. That's off the table. What needs to be stated is it monoamniotic or monocorionic. That needs to be up front. If it's dichorionic, congratulations, get a bigger house, start saving your money, you got 2 college educations, but you're going to be okay. If it's monocorionic, shift gears. This is a truly at-risk pregnancy that's going to have a lot of work to follow. My hair is going to get grayer, okay, but that's really what you need to establish, and establish it early as stated earlier. Take-home message. You forget everything else that I said and the previous speaker said. 2 is better than 1. You want to know the chorionicity, okay? Remember that. And what do we know about that? There's a hidden mortality here in this situation. A lot of these losses are early on in monocorionic pregnancies, well before 24 weeks. It's a sin in my community, okay? We will have situations where they establish chorionicity, congratulations, and they bring them back at 20 weeks, 8 weeks' time. And things have just gotten really crazy during that time period. So it's important to watch them serially as well. One of the things that we know when we look at monocorianicity, there's a higher incidence of prematurity, there's a higher incidence of low birth weight. What do we associate with cerebral palsy? Low birth weight, preterm delivery. So collectively, monocorionic twins intuitively have a higher incidence of complications. This is a report from Dr. Louis in Belgium where she followed 200 cases prospectively to help us really understand, because everything to date had been retrospective. This is solid data from first trimester on, where serial ultrasounds were done every 4 weeks to watch and see what happened in these monocorionic twins. And what we see is that the singleton death is about 7%, the dual death about 7%. Twin-twin transfusion syndrome, 9%, but really the bane of our existence right now is this selective growth restriction. What do we do with those? Again, I'll leave that to the next speaker to handle that one. That's too hard for me. In a situation where we look at these losses, again, it's a hidden mortality. It's lost early on. We look at them less than 24 weeks. So we need to be seeing these cases earlier. Still, though, we see things later, and we need to follow them continually. So again, monocorionic twins, you lock them in, you see them often, you see them frequently. If you're lucky, their uterus glows in the dark when you're done. You've scanned them so much. All twins in our unit get a growth ultrasound, a comprehensive ultrasound at 18 to 20 weeks. If they're dichorionic, it's every 4 weeks. If they're monocorionic, it's every 2 weeks. And we'll alternate that with our generalists. In simple studies, it's just looking. Are the fluids concordant? Do we see bladders? Do we see anything subtle? If something, now in our unit, we're going to do a lot of Dopplers and do a lot of different evaluations. But as a general rule, if the fluids are good and the bladders are good, you're going to be okay in that group collectively. Twin-twin transfusion syndrome. As I said, 9 to 15%, roughly 1 in 60 twin pregnancies, 1 in 4,000. If it presents less than 26 weeks, a 90% perinatal mortality disease. This is a bad disease. About 1 in 1,500 pregnancies, there will be 1,500 pregnancies in the U.S. this year that have this disease. I don't know what your population rate is, your birth rate is here, but if you start doing some numbers, again, 1 in 170, a third of that, you're looking at roughly probably 1 in 900 pregnancies are going to be affected in this country. So you ought to think about it and looking at them. What is it? It's easy to say to the patient, well, it's an exchange of blood from one fetus to the next fetus. In reality, it's much more complex than, as you know. But it's a process of vasoactive response transferring through, and it's related to the communication that we see in the placentas, this anastomotic processes. And primarily it has to do with the arterial-venous anastomoses, where the arterial anastomoses are protected. Now, I moved to Texas about 3 years ago. This is the only animal model for monocorionic twins. Unfortunately, or fortunately, it doesn't get twin-twin transfusion syndrome, because this would be a real sucker to take on with regard, you need armor to test these guys. So what we have to rely on are computer models. And some work that was done in Amsterdam not too long ago came up with this formula. All right? Now, I challenge anyone here to memorize this formula, right, as to what the result of twin-twin transfusion syndrome is. And this is why I'm an obstetrician and not an engineer. All right? I can't even read that, but it truly works. What we know clinically is we have a single placenta. It's monocorionic. We see discordant amniotic fluid volumes. Obviously, they're concordant for sex. Sometimes they're discordant in size, but that may not be early on. There can be a discordance in the placental echogenicity. Quite often, you'll see the donor placenta very thickened and very white. It's hypoechoic because of poor vascularization. The recipient twin is going to have a large bladder. The donor twin is going to have a small bladder or non-visible. This is a representation of a Texas tuck twin. In reality, if you look, you can see these are the feet of the donor stuck with the membrane around it. This is an image just showing the membrane. The membrane is flaccid, the recipient, and you see vessels going across the membrane. Caricature showing you that the common denominator here are these vascular anastomoses. They are present essentially in all monocorial twins. So why is it that 15%, 9% kick into trouble and the rest are doing fine? We still don't know yet what trips it off. This is a placenta of a monocorial twin, showing you what we typically see is this eccentric marginal donor cord, and what you're seeing is an arteriovenous anastomosis, and this white cord coming out is the recipient cord. In this situation, flow is balanced because you have an arterial anastomosis. It's simply a loop going around, okay, in this communication. This is fine. Now, what ends up being one of the primary problems we see is the reduction in arterial anastomosis in twin-twin transfusion syndrome. And the problem is trying to be able to detect these and see if we can really dictate who will or will not actually evolve into the disease overall. What do you see clinically? Well, the recipient is going to develop polyhydramnios. This is actually a cardiovascular disease if you really start thinking about it. He's going to get into chest heart failure, there's arterial thrombosis, and it'll eventually develop hydrops. There are 23 cases in the world's literature right now of an amputation in the recipient twin due to what we think is thrombosis, and of that, 90% are above the knee, left side. $100 to the person in the room that can figure out why that happens, because I still can't figure it out, and neither can anyone else. The donor is going to get oligohydramnios, it's going to become growth restricted, there's going to be vasoconstriction and inorganic damage. Bottom line is, as I said a second ago, 90% of the time there is a bad outcome. 60 to 70% of the time you lose both. In 20 to 30% of the cases you will lose one and the other one will have severe neurologic damage. Nuchal translucency. If you believe Kipros-Nicolaides, this will also tell you whether or not your child is going to go to the university, NT measurements. Now, that may or may not be true, but in and of itself, it does provide us some information. Discordancy in NTs that we see will be present in about 11% of TTDS cases, and it does provide us some information, although other centers, such as the Copenhagen report here, didn't see that. The reality is, when you see an increased NT, you're going to follow that pregnancy anyway very aggressively because of the other issues. So the likelihood of missing a twin-twin case with an increased NT, I think quite frankly is low. Next, what you see here is actually a situation where you've got an invaginate enfolding of the membrane. On the left is the recipient fluid, totally encompassing this co-twin, and the membrane is truncating down. Now, this is being done in about 15 to 17 weeks, and the reality is you're seeing discordant fluid volumes, so that's already kicked you off. So again, as a marker, it may or may not work. There is some predictive value, but you've already got the patient in queue for ultrasound. So the reality is you see it, it helps you understand, you need to watch the pregnancy closer, but is it really going to help you much more than that? I don't think so. Arterial anastomoses, if they're present, okay, we find that you reduce the risk of twin-twin. If they're absent, it increases, and not just twin-twin, but it actually reduces perinatal mortality when they're present, okay, with or without twin-twin. The majority are only detectable after 18 weeks, so again, the reality is you've already locked the patient in to serial ultrasounds, so you're really already doing the studies. So I really don't know, again, the practicality of it, because the major problem is if you don't see them, you don't really know, is it I didn't see them, are they absent, what's the problem here? So again, it's a test that we still sort of need to work on. Velleman's cord insertion, we all thought that was the situation based on this report from 1993. That was a pathologic study of twin-twin cases. But when you looked at the prospective work done from the group in the Netherlands, the reality is it really doesn't hold. Okay, because actually you can see Velleman's insertion quite often in a recipient twin as well. Some recent work again by Louis, going back to looking at the same group that you follow prospectively, discordance in growth, crown rump length, discordant amniotic fluid volume, and combining the two probably again provide us some information. But we really don't have a good predictor at this point in time, so it does simply fall back to serial ultrasounds. Now, Ruben Quintero has made a career off of 83 patients, the Quintero staging, all right? And most in this room may know it, but I'm just going to walk through it again. And staging it was designed originally to help that we thought there'd be a natural progression from stage 1 on to help us better understand the pathophysiology. But the reality is you can sit at stage 1 for just weeks and do nothing. Or you can be at stage 1 on Monday and stage 3 on Friday and high drops on Monday, the following. So it's really, it tells me when you call me what you're looking at right now. That I understand. I don't know what's going to be a week from now. So the reality is when you see this, you need to be aggressive in your observation. Stage 1 is discordant amniotic fluid volumes. Too much, too little. The arbitrary cutoff that we use is less than 2 or greater than 8. In Europe, they'll use over 20 weeks greater than 10. You can argue that point till the cows come home. You won't get an answer. Absent bladder in stage 2. Dopplers are abnormal in stage 3. And some have argued that the stage 3 is primarily a donor stage, if you will, in the context. Looking at ductus venosus, looking at umbilical artery, looking at umbilical vein, and helping us understand. If they're abnormal on the donor side, we call it a stage 3D. If they're abnormal on the recipient side, we call it a stage 3R, just to help us understand. And in stage 4, you've resulted in high drops in the recipient. In stage 5, one or both are dead. Now, the group from CHOP in Cincinnati and others in Europe have looked at this and said, again, this is a cardiovascular disease primarily representing the recipient, and have developed various scoring techniques. This is the one that we look at from the CHOP group, and if we try and apply that to the Quintero staging going through, you can see that the various scorings run through, and they don't totally match up. So here you are looking at a situation where a cardiovascular score of 2 at CHOP, 12% in stage 1, 35% in stage 2. 20% of stage 3 in Quintero actually have a normal CHOP score, if you will. So it's not quite clear how we integrate the cardiac findings in twin-twin transfusion and how they help us move along. It's clearly something where more research is needed. The primary therapy that's been out for the longest time is amnio reduction. It's universally available. We've all got a needle. We can reduce the sac, and actually it does work. It does work. And if you're in a pinch, it can do the thing. If you think about the intrauterine pressure compressing the placental mass, you do reduce flow. The problem with it is when it doesn't work, you can get yourself into a situation where you compromise definitive therapy. If you want to have if you want to have some fun, throw this slide up, get 10 perinatologists in the room, and put them in a circle, and you will see everything but a fist fight about this particular observation, microseptostomy. There are those that are passionate about it, that feel that it truly works. There are others that say it's absolutely the most ridiculous thing I could think of doing. The problem with this particular observation is that some people have been very aggressive with it. Not just one needle going in to reduce, but actually taking 2 or 3, making Swiss cheese, if you would, of the membrane. And then what happens is you get a rent. So like you don't have enough problems, you now have created a monoamniotic twin pregnancy with twin-twin transfusion syndrome. Just escalate your headache. Or you get a hole in the sac, and there are a number of cases where actually the cord of one fetus has knuckled into this membrane defect, and you've got a cord compression. You lose one, you lose the other. Microseptostomy, really, if you're going to use it, maybe late in the game when you're past 28 weeks, but really has no role early on in therapy. Julian D'Elia in 1990 did the first report on use in humans. Actually, prior to that, he'd done the work in rhesus monkeys showing that you can ablate placenta. I remember when Julian presented this particular work at the International Fetal Medicine and Surgery Society meeting. He was laughed off the stage. But that was absolutely the most ridiculous thing in the world to think that you're going to put a fetoscope in and you're going to close these vessels. And quite frankly, it has now become the standard of care. I draw your attention to the fact in Julian's original report, two-thirds of the fetuses survived, all right? How far have we come? Well, again, laser, it's simply looking for the anastomoses. What we're going to do is we're going to map them, we're going to close them, all right? What do we see now in these large center reports? How many babies have survived? 2/3. It's a bad disease. There is more to this disease than simply closing the portals. There is probably a medical component that we haven't got our hands around yet. But we do all know now that the definitive therapy is laser in the context, if you look at outcomes, clearly from the standpoint of dual death, overall death, less perinatal death, neonatal death, and that neurologic outcome, you can change that to 2 years now, okay? Because actually there is clearly evidence showing that these are all improved with the use of laser. This is just showing the learning curve like anything else. The more you do, the better you get. The yellow bar is showing 1 survivor, the blue bar is showing 2 survivors, or the ever popular at least 1 baby surviving. And as you can see, looking at Julian's work, looking at the group from Hamburg, looking at the group from Paris, all get better the more you do. If we look at large center studies, again, this is the original report. This is the Eurofetus randomized trial showing where the data is. There's survival of 2. There's survival of at least 1. And that's just some home cooking. That's our work at UNC, at Baylor. What are we looking at? Well, this is what we do. You're going to be basically using a single punch technique percutaneously. We'll find the recipient cord. we will map this vessel to its terminus. Hopefully it terminates with a vessel of its own and returns. In this particular situation, you're watching these vessels move across, and we know the donor's in the upper left-hand corner here. Again, going to be looking for the vessels. You'll see the membrane compressed there. There's the donor membrane. There's the donor foot. And as we return back, we're going to look for anastomoses and track and see. Are these good or are these bad? Coming down. This one hooks back to your left there, goes back to donor. That's good. Coming down. Again, big vessel coming down, nice artery. And communicates right there. There's an artery vein communication. There's another one that is passed over, going back to the recipient, again confirming what we see. And we will do this and map each vessel in a systematic process. And then this situation, 17 weeks, we'd use a 400 micron laser fiber coming in with about 25 watts of energy and simply ablate, we will close them in this fashion of artery vein, and then vein artery using the donor as a reference point. And do this across the way. There are complications with these, and intraoperatively, if an overly distended uterus, what you can have is a rapid expansion of amniotic fluid leaking out, and what happens, that decompresses the recipient sac. You can no longer see. Everything's just come down on top of you. Postoperative pain can be in place. There's some bleeding. Abruption is the big one. A rapid decompression of this uterus can cause literally shearing of the placenta off the surface. But the big headache everyone has is premature rupture of membranes. 30% prior to 34 weeks in every study, every center. Some will tell you that, well, our procedure-related prom is within 2 weeks, such and such. It doesn't matter. The membranes do not heal. So if you have prom, it's most certainly related or has something to do with what you did. What about recurrence of TTTS or something called TAPS, like you don't have enough acronyms, twin anemia polycythemia sequence? It's reported that it will occur in about 14 to 13%. We've not seen it that often at Baylor, but one suggestion was that maybe there's a problem with persistent communication. Again, some work from Elizabeth Louis showing us that in this situation, even with dual survivors, 20% you'll find some communication of some sort. In double deaths, they're definitely there. So we're missing vessels. Are we missing dead vessels? Are we cannulating? What's going on? Well, there's what we call little hairs, if you will, or spiders, that actually under an increased pressure probably will increase in size and result in either TAPS or, again, recurrent twin-twin. One suggestion has been to basically dichorionize the placenta, something called solemnization. And what you simply do is you take your laser beam and go up there after you've closed the primary vessels and sweep across. There's a trial presently underway in Europe looking at this observation. We have actually simply incorporated this in our program over the past year, and in the last 75 cases we've not seen anything. It's still too early to tell. Outcome. Neurologic outcome. All right. What we see there really is no difference in the donor and recipient with regard to long-term neurologic morbidity. And this seems to be primarily related to gestational age of delivery, not related to anything else that we can see. It is a cardiovascular disease. 8% of recipient twins will have cardiac complications, pulmonary stenosis. I haven't the slightest idea why the donors in this particular study had ASDs. But again, I think that all babies that are the products of twin-twin transfusion syndrome warrant having echoes after they're born to see what's going on. Okay, where are we in the U.S.? This is pretty much what we're doing now. Stage 2, 3, and 4 are going to be referred to lasers in most situations if there's proximity. If you have an unfortunate situation where you have a loss of one, some have argued that maybe you do an emergency intravenous transfusion. The literature out there is really suggesting that probably isn't going to do much for you. It's an unfortunate situation, and probably observation is what you want to see, and follow the fetus, and hopefully what you won't see are intracranial changes. Some have argued for early MRI to take a look and see if you can pick up an insult. Again, the literature's out there. It's still to be seen. The big question now is what to do with stage 1. Well, the Eurofetus trial didn't answer the question, although some would argue it did. There was only 11% of the cases actually were in stage 1 disease, so we really don't know what's happened there. What we know right now remains controversial. Expect an observation less than 26 weeks. If you're going to do that, you need to watch at least every week to twice a week, depending on what you're looking at. Amnio reduction, may be an option if laser isn't available. The problem that with amnio reduction, Actually, you may not need to do it. There may be regression or stabilization in some 25 to 50%. Doing an amnio reduction actually can get you into more troubles than it's worth with a chorioamnion separation in about 8%, or an inadvertent septostomy, which means if you do progress, then you're in real serious trouble with regard to laser. Laser, if you look at the reports, the stage 1 cases, they actually are harder procedures because you have less fluid in most cases to work with, and there may be a higher failure rate. There's move afoot right now to put forth another randomized trial to look at stage 1 disease. This will probably be starting again within the next year in Europe. Is this as good as it gets? Well, 2 healthy survivors delivered only 30 to 40%. Actually, the literature would suggest now that with increased experience, those numbers are going up. That what you're seeing now probably are dual survivors in the 60% range or more. Still, what are we doing in trying to improve this? I think that maybe looking earlier may be an alternative to what's going on, but I truly think that twin-twin transfusion in the syndrome in the future will be a surgical medical disease. There'll be a process where we'll be able to evaluate the fetuses and see what's going on. Right now, many of us would argue if you look at the way the recipient's responding, something like an ACE inhibitor would be a good thing to give to that fetus. But in the presence of communications, that could be the worst thing that you would give because the donor would then get that totally shut down its kidneys, and that would be a death sentence for that fetus. So where we're going and where it is, it's yet to be determined. But laser is kind of like shutting the barn door after the horse is already out. You've already got the disease. So we now have to find another way to come back and recover, and I think the future is wide open in this regard. Thank you.